So for the next half an hour, we will talk about the health survey design and what is actually our experience in the UK. So as Dr. Santi has explained before, that we are part of the research STAN project, and then survey is a big part of the project. So what is actually the survey design and how we do that? Survey design is a part of a big research that we have done, and always start with a question. So actually when we design a survey, the first thing that came up in our mind is actually what would we like to know? What do we want to know? For example, it's always start with a question. This is one of the example of the oldest question, for example. So what is actually considered as healthy? Is it a physical health? But nowadays we have also mental health. What is healthy in a previous time, and is what is healthy now? It is also a question that we would like to answer. And then probably the question that is popular right now, the people who are now turning into eating more vegetables, and then some people is then going vegan, and then when, how, and why is going vegan can improve your health is one of the question. And then nowadays is also we have a lot of chronic diseases. How can we improve the health of the people who have chronic diseases? And the most important thing is also in the STAN project is what is depression and anxiety? How can we treat depression and anxiety? Is it a threat of our health? Should we separate depression and anxiety from our physical health? And what is a good intervention for it? This is one of many questions in health that we would like to answer. To answer that question, we have a lot of methods, and one of the methods is actually the survey research. Survey research is actually we would like to ask the people, we would like to talk with people, but we in different with the qualitative research or different with the other narrative research. For example, surveys will use a structured and a standardized questionnaire. Why do we use a structured and standardized questionnaire? It is actually going into the aim is actually we would like to be able to quantify it. So we would like to be able to calculate that. This is why we use a structured or standardized questionnaire. For example, rather than asking what is your gender? What is your gender? People can answer anything. But then we would like to quantify how many percentage are males, how many percentage are females, and then we then ask, what is your gender? And then we give two choices, males and females. This is one of the question. For example, if we would like to ask people, how old are you? People, if we all have an open question, and then people can answer, I'm 25 years old and 3 months, for example. Some people do not put months in their answer. It will be quite difficult to quantify. However, if we use structure and standardized questionnaire, how old are you in years, and then people they can answer 25 years old, 26 years old, etc. So that's what the aim of doing the survey research, because we would like to quantify our result, and then we would like to then analyze the results using quantitative analysis. A lot of framework actually in health survey. For example, we have here the characteristic of environment, characteristic of healthcare system and population, and how it affect the health status. And then how then we behave in our health seeking behavior, for example. And then how much we spend money for going to the healthcare services, and then whether we satisfy or not with the healthcare services, and then how will it then affecting our adherence in our treatments, whether we then would like to look at the healthcare, or we will go for another visit to GP if we are satisfied with the GP, for example, and then we will then going back to the GP again. All of those framework is actually can be done in the healthcare survey. I think the most dreading question is, how will we design the survey? This one is need a lot of thoughts. This part needs a lot of thoughts before we then can go for designing the questionnaire and everything else. This is actually all the process of designing the survey. I understand it can be like very like a lot of process. We need to have to study first what is our research question, how will we answer our research question, and then we need to design the sample, design the questionnaire, and then adapt the survey instrument. For example, when we would like to measuring the mental health, we have CESD. CESD has been performed, for example, in America, UK, and everywhere else. But to be able to perform that in Indonesia, we need to adapt the survey instrument. Translation, back-to-back translation, and then we need then recruiting the interviewer, selection, training, and then data collection, and then data harmonization, and then disseminate the data. Between the adaptation and the data collection, we need to have also the pilot study. So all of this circle is needs to be performed, and then if we already like going for the data dissemination, there is probably a lot of feedback again, and then we going back again into the circle. To plan or design the survey, there are actually 3 main questions that we would like to answer. The first one is whether we would like to sampling the survey or an experiment. I will explain later about the modeling of or the design of the research. And then how will we choose the people of the subject of the study? And then what is the question we would like to answer? Whether we would like to answer a descriptive question, which is actually we would like only like graphical or summarizing the data. So I don't want to remind we all on the COVID-19, but if you can remember during the COVID-19, and then in the television, the government always announced how many people got the COVID, how many people got hospitalized from the COVID. It is descriptive data because it's only graphing and summarize the numbers. And then the second one is the inferential one, which we will make the prediction based on the data. Rather than having the number of the people getting COVID, we would like to know who actually get the COVID, whether age is actually a predictor for COVID-19. So if people getting old, and then the risk is higher, whether gender is actually a predictor of getting the COVID-19. Males, for example, more vulnerable to COVID-19, for example. So this is the inferential data. What question we would like to ask? Another thing that we need to consider is whether we would like to do a cross-sectional study or whether we would like to do a longitudinal study. Cross-sectional study is we collect the data at one point of time. It is easier because then we do not need to consider taking the data into the same person of a time. However, it less strong than the longitudinal study. Longitudinal study itself, it has 3 different or 4 different types. The first one is like trend. we just look at the changes of the population over time, like the census. So we collect the data in 2010, and then we collect the data again in the 2020, for example. And then that's it. And then, but the data can come from different people. While in a cohort study, one step ahead, we collect the data in the same group of the people who share common characteristic over time. For example, we collect the data on the older people, age 60 years old and older this year, and then the next year and the next year. However, if we collect the data from the same person, it will be called the panel study. So the panel study is the most difficult data collection compared to the other longitudinal study and cross-sectional survey, because we need to do or to get the data from the same respondent. So for example, like me, if I am a respondent of the panel data, and then they collect my data in 2002, for example, and then they would like to collect data again in the next wave in 2004, they need to going back to me again. And they will need to find me wherever I go. So if I move to the other place, and then they need to find the person, because they need to get the data from the same person over time. It is called panel study. And then this is the question that is usually we need to think about before we collect the data. Is the survey necessary? And yes, what is the purpose to do the survey? And then can the data be obtained by other means rather than survey? Because survey can be quite challenging, difficult, and expensive. And what type of the survey? And then how can we got the completion rates, and how will we deal with non-respondent? But I will explain it step by step. So I have promised that I would like to explain to you also about our experience in the UK. And for the experience in the UK, I would like to bring you into our panel data study called English Longitudinal Study of Aging. So what is our survey about? It's actually, as we know, that the population is aging. It's not only in the UK, everywhere in the world. That now people can live longer. Even in the UK, previously only 1% who born in 1908 can live into 100. And people who can live up into 100 years old in the UK get a very special treatment from the Queen and the King. Now, as the King, they will get a specific birthday card. Congratulations, you reach for your 100-year birthday, years of birthday. And then the card is signed by the Queen and sent by the Queen herself when she was still alive. And then now as King will send the card. So being 100 years old is very, very special. But nowadays, if we born in 2012, a third of us will be expected to survive into 100 years. So children who born in 2012, a third of them will be expected to survive and live until 100 years. So we can imagine that in 2112, there will be million of people aged 100 years old. Because of this population aging, then we would like to know how it impacts into the population. If we can see here, it will increase the hospitalization by older and hospitalization more will be by older people. It will increase social care because more social care nursing home will be designed for the older people. And some older people, they probably have limitation, but they live alone. For example, now in the UK here, there is a Meals on Wheels. So Meals on Wheels is like if people delivering meals to home for the older people. So this is example how people supporting older people living at home. So to know how this population aging affecting the health and mental health of the people in the UK, and then we then design the English longitudinal study of aging. The English longitudinal study of aging itself is looking at or collect the information on health, social, well-being, and economic circumstances in English population aged 50 and older. The participants are around 18,000 people, and it is already going on for 20 years since 2002 and have 9 waves. So ELSA, so I will call it ELSA. ELSA, or English Longitudinal Study of Aging, ELSA, is a panel, one of good example of panel study. So it's collect the information from the same participants every 2 years up until 9 waves. Now they are collecting the data for the 10 waves. So we will have the data on the 20 years of one person span into the 20 years. And the data is available for the researcher and has more 1,000 publication. The sample itself is people aged 50 and older living in the private household. So it is only people who are living at homes. For the first wave, the sample is 11,578 households and containing 18,813 eligible individuals. Because of the attrition, people drop out. And with 3, 4, 6, 7, and 9, we did replenish or refreshment. We inviting a new people coming to the ELSA to replace the people who are drop out. Usually people who are drop out because they are moved into the nursing home. They are very sick, got dementia, for example, or have a mental health problem or physical health problem, and then or they died. So people tend to drop out because this is older people, representation of older people. So if they drop out and then we need to replace them, and then we have then refreshment. The question we have around household health, and then the health, social care, work and pension. Pension is important because this is older people. Income, housing, cognitive function, social participation, effort and rewards, expectation, working speed and weight, and we have also biomarkers. So we take blood samples, for example, like cholesterol, CRP, fasting blood glucose, and several other blood samples. Some people in ELSA also got sampling for genetics. Now, how we calculate our sample? We cannot deny that survey is very, very expensive. And then we could not sampling all population. We could not get a survey from all population. For example, Indonesia is 70 million people. So many people. We could not sampling all of the population. Then we need to collect only a few people based on our ability, our funding, our money. So that's why then we need to work with the sample, which is called statistic sample. And then because of we have the sampling only, and then we can then get the data from the sample only. From the data from the sample only is called statistics, and then from this statistic, and then we look at that how we generalize into the population or parameter. And a good sampling process should be randomized, because then it can represent the population, and then it should be also stratified based on the characteristic of the population. I will explain later. So there are a lot of randomization. So randomized means that we need to do it at random. So it can't be, so if we are not doing it random, and then we will tend to get sample from the specific people, which is much better people. For example, if we would like to sampling older people, if we are not doing it in random, we will tend to sampling healthy people, because healthy people is the one who easy to reach. They are not bedridden or stay in bed, for example, so they can answer the question, for example, easier rather than people probably have a mental health problem or physical health. So if we do not doing it in random, we will tend to sampling also, for example, wealthier people or people who are not working, for example. Because if we go to the houses in the afternoon, people who are working, they already in office or something like that, and we could not get the data. The one that we meet is actually people who are not in the office or staying at home. So to avoid all of those non-random things, we will need to do a random sampling. Random sampling, we need to do it to reduce the bias. Some people can do it simple random sampling. So simple random sampling is like bingo or something like that. So we put all the people into numbers into the jar, and then we put it in random. Simple random sampling. Systematic random sampling is we numbering the people, and then we then select the subject in the first K name, for example, for the sampling frame. So we have the sampling frame, and then we put the random from the sampling frame. And then stratified random sampling, if we divide the population into strata, for example, our population is, for example, this is one of example. Probably our population like 60% females and then 40% males, for example, in the population. And then we then would like to stratify our sample. It should be 60% males, 60% females, and then 40% males. Or we have people who are very old, 75 years old and older, for example, only 20%, then we would like also have 20% of those age group in our sample. So it is stratified random sampling. Cluster is usually if we have, we need to do the survey in 5 different districts. For example, in our STAN project, or for example, also in ELSA in the UK, we have 4 different region: Northwest, Southwest, Midlands, and Central. So 4, and then we will then need to sampling based on the those four areas. And then multi-stage sampling, if we use the combination of all of those 4 sampling. And then we need then to avoid the sampling errors by doing the randomization. And then that's the first one. And then the second one is we need to calculate the number of the sample to be able to have the good power calculation. The good power calculation is around, the rules is around 80 into higher than 80 or higher than 90%. In ELSA, we have it higher than 90%. But because ELSA have a lot of respondents, if you have lower than that, and then you then needs to increase the number of the sample. So this way, for example, like if we sampling an area of, let's say in Indonesia, for example, Jakarta, for example, we can do it by 11,000 people, for example, but we need to make sure that it is randomized, and then we need to make sure that it's stratified based on the characteristic that we would like to sampling. Sample size calculation will be another hour of talk, but let me go for the next thing. Probably we can do it in the next time about how to calculate the sample. And then there are a lot of sampling bias that we would like to avoid. So for example, like we cannot only have volunteer sampling. So volunteer is people, oh, I would like to be sampling. No, we cannot have that because it will lead into the sampling bias. So we need to choose our sample rather than the sample coming by him or himself to us. And then the response bias is if there is a poorly worded question, I will give some example later. And non-response bias if there are people who are not attending the sample. And then to be able to avoid those bias, we do the reliability, external validity, and internal validity of the sample. Reliability test can be any of the people who are in the psychology, for example, they would like to do compound alpha to do the reliability, and some other reliability, for example, like using the histogram and then to looking at the distribution of the data. For ELSA itself, how we sampling ELSA? We sampling ELSA based on the health survey for England, which is representative of the population. And this one, we use postcode. So in English, in England, rather than we use, so for example, in Indonesia, I think we have also postcode. In England, we also use postcode of the address. So we have hierarchically region and then population density. So for example, London have a very highly density of the population, while Bradford, for example, a very low density, and then London will have more respondent than Bradford. And then we cluster all of those people into 19,500 clustered, and then while the unclustered one, we will not choose that, for example, for a very low density population and also for ethnic minorities. And also we are not included people who living in the residential care. We are not included people who are living on the street, like sleeping in the street, and then prisons and temporary housing. So we then look at the postcode of the people and then sending email to the people. Sending email to the people and mail to the people, letter of invitation to include it in our sample. So we need to ensure that every single city or area or district will be covered by ELSA. So designing the questionnaire, probably I will go a bit faster. And designing the questionnaire itself, we need to be very good, and then it should be competent, and then the questionnaire should be very good, and then people can answer this. This is can be a bit difficult. I think our colleagues in STAN really understand how difficult it is to make a questionnaire. So the questionnaire, first of all, should be answer our question. And then we need to avoid negative term and double barrel question. For example, I will give example later. And then the question should be relevant to the respondent. If we ask young people, we will not ask about pension. It's one of the example. They will not answer about pension. And then the respondent should be can answer the question not in a bias response. The types of the questionnaire we can have is interview survey, the telephone survey, and the online survey. Interview if we come to the house, telephone if we call them in the telephone, and online if we use BIS survey. This is example of the computerized data collection. Nowadays we use computerized data collection. CAPI is the computer assisted personal interviewing that we are now using for STAN. ELSA also use CAPI, and website, for example, is we have a internet survey or web-based survey. Nowadays, I think a lot of survey, we just give a link into the emails, and then people can then click the link and then answer the survey. What are we doing in ELSA? we in ELSA, we have a face-to-face interview, and then we use a computer-assisted personal interview or CHAPI. So the people came to house and having a tablet like iPad tablets, and then they will answer question and put the answer into the iPad, and then with 2, 4, 6, and 8, the nurse come to the home. The nurse come to the houses, collect the data on cognitive function, and also collect the data on the blood biomarkers. So they took the data and then they bring they took the blood and then they bring the blood into the lab. So we send the people advance letter, invite the people to take part into ELSA, and then before the work we briefing the interviewer, and then the interviewer then call the people, or they visit the household, explain the study, and then they make appointment where should they come again to the houses, and then they will collect the data in the house. Nah, if you remember that I explained that ELSA is a panel data, that the same people get the data collected every 2 years. That's why then they need to tracing the movers. So if the people moving address, and then ELSA then will trace where the people move. But English have a very good notes on how people move. So yeah, so they can trace them using the data from the district government. I think this is a bit. So this is a type of the question format here. So we have the open-ended question and closed-ended question. This is the statement. This is the example of the question. This is example of the open-ended question. For example, like what are your challenges in making to the general practitioner? General practitioner in Indonesia is like a general doctor, not a specialist. So what is the challenges of making a GP appointment? And then people can then answer in this one, anything. And then when you are under a lot of stress, for example, what is your typical reaction? And then people can answer it in this. So open-ended question is more like we have a question, and then people can have a leeway, or people can answer whatever they want, and then we then put the answer into the CHAPI. While the closed-ended question is more like we give the choices to them. So it can be, for example, if age, I give example, if in years of income in pound sterling, we can give numbers like this. So they only can answer the numbers. For example, like this one. Thinking about number 57, thinking about your health in general. Do you generally prefer to live at the moment or live in for the future? So they will like, yes, I live for the moment. They will answer 0, live on the future, 10, between those, and then they can tick any of the boxes. So this is the close-ended question. Rather than giving freedom for the respondents to answer, we can give them numbers, or we can give them choices. So this is what several tips to make a question clear. For example,
can you shorten the explanation because time will be up soon.
Okay, yeah, this is, I think it's only tips, Pak Ariana, and then I will finish with after the tips. Thank you. And then we need to make the question clear. For example, like how many weeks were you employed in employment last year? Last year is unclear. It can be 1 January into 31st December, in the last 12 months. And then we can make it clearer, like how many weeks were you in the employment during the last 12 months, since when into when. And then are you employed full-time? Full-time can be anything. for a medical doctor, for example, full time can be working on the Saturday and Sunday also. So full time, and then you need to define what is full time. Are you employed at least 35 hours a week? This is how we make a question in ELSA. Double barrel question, we need to avoid this. Double barrel question is if you have a question with two choices. For example, like how good is your eyesight for seeing things at a distance or up close? People can have a difficulties in seeing at a distance or seeing up close, either one or two. And then we need to divide this question into two. How good is your eyesight for seeing things at distance, or how good is your eyesight for seeing things up close? This is loaded question. We need to avoid this. Like, how often do you exercise? Twice a day, for example. We assume the respondent exercise regularly. No, we cannot ask something like that. We need to ask them, do you exercise regularly? If the respondent answer yes, and then you then ask, how often do you exercise? And avoid the negative and double negative question. For example, if you would like to ask, is the hospital facility is unclean? And then people will say, oh, is it unclean? People will assume that the hospital is unclean. And then you then ask, how would you rate the cleanliness of the hospital, for example? And the same example for the website. And final thing is ethics. We need to keep confidential of the private information. And we need to say that we will keep your information private, and we will minimize possibility to causing the psychological discomfort or something like that. And then we, if possible, we use Chapi or paper-based to like avoid rather than only like face-to-face, to avoid that our information all are recorded very well. Oh, thank you. And I think I will return the session to Pak Ariana.
Thank you very much, Dr. Asri Maharani. It's very interesting to understand about one example of the big research in UK. It's about ELSA, English Longitudinal Study of Aging. It is a panel study for over 20 years in 9 waves and involved about 18,000 individuals. It's very, very big study, and it includes some information regarding demography, income, cognitive, social network, even also include the taking of biomarker, blood sample, and tracing moves. Okay, I think the second speaker will share with us about how the health survey conducted in Indonesia. Dr. Sri Idayani has worked in BRIN since 2004. She got her undergrad medical doctor from Universitas Sriwijaya, then earned her master's from Universitas Diponegoro, and took his PhD doctoral level from Faculty of Health from Universitas Indonesia. Dr. Sri Idayani actually is the responsible for the health mental block from the basic research, health research, or we know as Riskesdas, in 2018. She also has published numerous publications, particularly in mental health, including mental health in aging people or elderly individual, also depression-based and national health survey. Also, she in charge also about the effectiveness of COVID vaccine. I think it's very interesting that we got the speaker from Dr. Sri Idayani. Time and place is yours, Dr. Ida.
Thank you, Pak Ariana. Just to check my voice, is it clear?
Yes, very good. And also we have seen your presentation.
Yes, thank you, Hani. Please display my PowerPoint. Good evening, good afternoon, everyone, or good morning,
In
everyone.
presentation, this in presentation, yeah, okay. Sorry, Dr. Ida.
Okay, thank you. Good evening, good afternoon, or good morning, everyone, depending on where you are. This presentation is based on my previous experience as a researcher in Ministry of Health. But now I already moved to the National Research and Innovation Agency, or BRIN, in Jakarta, Indonesia. Next slide, please. Yes, the first one, when we set the health survey, or especially the National Health Survey, we should set the background. What is the background of the survey? Usually we talk about the urgency, the need, the output, the research question. For example, why we need a health survey? Because lack of data, or probably the data is available but need to complement the existing data, or for evaluation the program because there is a gap, or we want to make the policy making. Next slide, please. Before we conducted the survey or the research, we have to make sure where the position or our work. For example, is it to assess the magnitude, to find the cause, to develop solution, to implement the solution, or to evaluate the something program. For Riskesdas, it is already clear just to assess the magnitude of the health problem. Next slide, please. Then we set the objectives. For example, in Riskesdas, the objective one, to assess the public health status and its determinant. The second one, to assess the change in public health status and indicators. And the third one, to assess the Health Development Index, or IPKM, change at the district or city level. So because we assess the change, so please we have to use the same indicator, the same questionnaire, and avoid the change of the questionnaire. Next slide, please. And then we set the conceptual frame. We collect the theory and literature. Riskesdas use or adapted the conceptual frame from the Bloom. Mentioned that the health status not only influenced by the individual factor, but also from the behavior, health service, biomedical, environmental, and demography and social economy. Next slide. The next step to set the method. The design should be a survey, and the location in Indonesia, all provinces and all districts and cities. The sampling frame, we use the census block that already that come from the Central Bureau Statistic, or BPS. In Riskesdas 2018, we used the Susanas 2018 sampling frame. And then the population was all household in Indonesia, in all provinces, all districts and cities, because at the time Indonesia have 34 provinces and 416 districts and 98 cities. After that, about the sample of the Riskesdas in 2018, the number of household is 300,000 household, and representation from district and also the national. The sample unit is census block. The number of census block is 30,000 census block, and the withdrawal of the penarikan sample is same with the Susenas. I cannot explain more here, but you can read in the report of Riskesdas that already available in website or in the Google. The number of the household per census block is 10 household. Next, please. Next slide, please, Hani. Do you have a problem, Hani?
Sorry, Dokter. Mbak Gemala has share screen.
Yes, please, Mbak Gemala.
Wait.
Gemala have a problem? Yes, thank you. Then we set the indicator. Next, Gemala. Yes, before the to set the indicator, we should because of the budget the budget for Riskes does come from the government. So the priority should be national priority. For example, the priority of Ministry of Health program indicator, the SPM standard pelayanan minimum or minimum standard minimum standard services, the SDGs, the IPKM, the healthy family program, the healthy movement or GERMAS. And then because this is the community based, so the unit analysis should the household unit or the household member, and then can be described by the cross-sectional design. So this is the cross-sectional, no follow-up and no intervention here. And then should be efficient in budget and implementation and data collection. So please avoid the complicated questionnaire. Just choose, for example, yes, no questionnaire or that easy one choices. And then we should involve the expert, the stakeholders, the academician. 1 year before the implementation, we invite them, ask their opinion, their input, their suggestion, the new perspective, probably. But in the end, the decision is based on the researcher or the team of the researcher. And don't forget to make the budget plan 2 years before the implementation. Next slide, please. Yes, this is, for example, the indicator of the Riskesdas. For health services, there are access to health services, health insurance, the therapy, the health service utilization, traditional health services, and the unit analysis is the household and household member. And representative for the district and city, and of course the national representative. Next. For health behavior, the indicator smoking, physical activity, alcohol, food consumption, hygiene behavior, the disease control or factor, the helmet use, and the unit analysis, mostly the household member except the disease control for factor. If I'm not mistaken, for example, the use of the net kelambu or the use of the pesticide bygone, for example, and representative for the district, city, and national. Next, please. For environmental, some supply and use of water, toilet use, waste disposal, trash disposal, then the unit analysis is household. And representative for district, city, and national. Next, for health status, there are communicable disease, non-communicable disease, mental health, for example, psychosis, depression, emotional disorder, oral health, maternal health, baby under 5 and adolescents, injury, nutrition status, disability. And the unit analysis mostly household member except the psychosis. And representative for district, city, and national. Next slide, please. For biomedical and oral health, the indicator is communicable disease, malaria, PD3I, penyakit yang dapat dicegah dengan imunisasi, hepatitis, risk factor of NCD, for example, glucose, lipid profile, and creatinine. And also the nutrition, anemia, hemoglobin, and for oral, hard and soft tissue of the oral. The unit analysis, household member, and representative for national only for biomedic. Next. Yes. Why we choose for mental health just psychosis, depression, and mental emotional? Because this is of burden. We already know depression contributes a large burden among the mental disorder. And we use the SRQ-20 for screening. We use this self-designed question for psychosis. The reason is because Risk-DAS is not pure mental health survey. It is impossible to use a special psychosis questionnaire. For example, for psychosis, the perfect one, we should use the snowballing method, for example, but it is impossible for Risk-DAS. Or probably we can use the special questionnaire for psychosis, but the enumerator should train well trained for psychosis. And then we choose a mini international neuropsychiatric interview for depression. And the validation testing already done in 2017. And we use mental emotional disorder using the SRQ-20 for assess the psychological distress. Sometimes people mention that it is not the disorder. Yes, it is correct. It is just the terminology, because the correct one is psychological stress. But this terminology has been used since the 1995 or since the SKRT or household survey, the old survey in Indonesia. The next slide, please. Yes, after that, we have to count the number of questions. For example, for communicable disease, there is 47 questions. For mental health, there is 29 questions, and total question for the individual questionnaire is 623 questions. For household survey, household questionnaire, the total number of questions is 78 questions. So the total question in Risk-DAS for household and individual is 701 questions. It is needed for calculation the duration of the survey. Next slide, please. Yes, this is the important ones to do the field organization. Next. The first one, make an organization chart by national level, Corwell or area level, provincial level. Then estimate the number of trainers, the number of enumerators, the person in charge, or we call it the PJT or PJO, penanggung jawab teknis and penanggung jawab operasional, the data management, and all teams. And then we should make a schedule, create a data collection scenario, and create a logistics scheme. Yes, this is the organization Riskesdas for the central level. The steering is usually the Minister of Health and the DGs. And the advisor is an academician, the health professional organization, and the academician. And because of the Riskesdas have two parts, the part one is biomedical. Two parts, but conducted simultaneously. The head or the coordinator of the biomedical Riskesdas is the director of a biomedical research center, and the coordinator for the public health is the public health research center. And under the director, there are biomedical technical team technical CASMAS or public health technical team, the management data, the expert. Yes, we use the expert. We invite the expert to be a validator for external validator. And also there are trainers, and we also have divided the Riskesdas organization. We divided into 5 Corwell 1, 2, 3, 4, and 5. And under the Corwell, there are provinces. Next. This is organization chart for the Corwell. The coordinator of Corwell is a director of the research center or Balai Besar. But the vice is the senior researcher. Under the Corwell, there are the PJT provinsi or provincial public health technical team, and there are PJT Kabupaten Kota, and there are enumerator. Beside that, we have the SAL. SAL is the staff administrasi lapangan. He or she is a people from the central and responsible for administration. But we also have the PJO, the operational head, the PAL, the administration logistic for provincial and for kabupaten or district. And but for PJO, PAL, and PJO district or city, and PAL district or city appointed by the district health office. Next, please.
Dr. Ida, another
Yes.
5 minutes. Another 5 minutes.
Yes. Okay. Thank you, Pak Ariana. This is the Corwell. You can see the Corwell 1, 2, 3, 4, and 5. This is the province. This is the responsible province. We can skip. Next slide, please. Yes. Then we set the activity of the Riskesdas 2 years before. We should propose the budget, and 1 year before we do the meeting with the expert and piloting. The first one we piloting to our close friend, our office boy, and then revise again the questionnaire, and then we try to the more groups, and then we choose one district or location near the Jakarta, for example, Cisarua or Tangerang, and revise again the questionnaire, and then we piloting to one province that have two location. The first one, the difficult location, and the second one, the easy location. For example, in North Sumatra, we choose Nias for representative for the difficult location and Kota Pematang Siantar for the easy location. And then we start with Rakornis in central level, usually launched by the Ministry of Health. And then we invite the stakeholder, we invite the organization of profession. Then we go to the province and we also held the Rakornis. At the Rakornis, we identify the difficult area, for example, the area that need to reach the area we need, for example, a special car, double garden, or a boat, or even the aircraft. And then we also identify the visibility of the enumerator, and also we check the Kesbang Pol permission. And after that, we do the recruitment of enumerator. We can do by the online, and we cooperate with the district health office, because the list of the enumerator usually came from the district health office, but we select together with the district health office. And then we ready to the training the enumerator in provincial. But before that, they are training enumerator in central level. After that, after the training enumerator in province, we ready to data collection. But before that, we coordinate again between the PJT, PJO, and enumerator. And after that, we the enumerator ready go to the location, accompanied by the BPS or census block, Central Bureau Statistic Officer, and accompanied also with the PJT. And after that, finish. Next slide, please. Yes, this is the scenario. For the first one, the data collection should be finished for 10 households in 3 days. So should be finished in interview, in blood pressure, and anthropometry examination. This is for the blood census block without the biomedical examination. And then they move to the next census block. Next slide, please. If the census block with the biomedical examination, so the scenario is the same, but in day 4, they held the field laboratory. After that, we moved to the next census block and conducted to interview the 10 households, and then held again the field laboratory, and then move to the next census block. Next. Yes. Don't forget to make the distribution and logistic submission in province. Then it is should be clear, should be finished in before the training activity, and do the BAST, berita acara serah terima, and after the data collection should be sent to the PJO, the district health office, and also using the BAST, berita acara serah terima. Next slide, please. Yes, this is the logistic of Riskesdas. We should list the paper material, for example, the questionnaire manual book, the biomedical manual book, the data management manual book, the buku peraga display book, the kartu hasil or result card, the informed consent, and the tools, the timbangan, the pengukur tinggi badan, the tensimeter digital, and so on. Next, please. This is for the biomedical. We should list the wing needle, the cryobank, the vacuum, the rag, and so on and so on. Next, please. Yes, the AcuCheck, the glucose strip, the hemoglobin, the RDT cassette, the loop, the buffer RDT, the alcohol swab, the silica gel, the blood lancet, and etc. Next slide, please. Yes, this is the distribution and return the public health and biomedical equipment. After, I already mentioned before that the equipment should be finished, should be received before the training. And after the data collection finished, the enumerator team have to send the rest of the material to the PJO or PJAL Kabupaten Kota district, and some of them to be a hibah, and only limited equipment or tools should be returned to the central, but mostly become a hibah to district health office. Next slide, please. Yes, I think this is all for me for this afternoon. Thank you very much for your attention.